Good evening, all. I'm Rohit Kotawde. I'm working as a senior product executive at Derma. Now, we are welcome you for the 8th episode of DADI, Dermapath Academy and Diagnostics India Private Limited, presenting analyze real-world dermatopathology cases and histopathology and educational support by Gloderma. Before starting our presentation, I would like to thank you to Dr. Sasi sir and Dr. Nandakumar sir to giving an opportunity to present here. Now I would like to start introduce about the Gloderma. So Gloderma have a core purpose that is elevating life and core value like a meaningful innovation, unwavering commitment to the quality and safety, continuous improvement, results through teamwork, and aspiration core value that is customer success above all else. Gloderma have a first time India product which is launched by more than seven, and we have a 400 plus enterprise in Glodermians. Gloderma have a 113th ranked pharma company in the country and 700 plus distribution network. We have a 9,000 plus associated dermatologists, as well as we have a skilled R&D team and develop innovation product. Gloderma have a product mix like an antifungal, moisturizer, acne care, and hair care. Along with that, we have a psoriasis care, topical steroid, vitiligo care, and nutraceuticals. Gloderma is India's first company who launched all product paraben-free, sulfate-free, and detergent-free. Along with that, we have a patient safety is of a paramount concern. Now, I would like to introduce about our flagship brand that is Moist. The Moist clinically proven range of moisturizer and cleanser. Moist is a non-comedogenic, non-irritating, and skin-friendly pH. So we have a range of complete moisturizing range. So in Moist we have a gentle cleanser that is Moist cleansing lotion and Moist scented bar. Along with that, we have a moisturizing cream that is Moist XL, Moist MM, and Moist cream. Moist XL available in 200 lime tube also. Along with that, we have a lotion that is Moist LMF 48 long moisturizing formula. So Moist every day, Moist day. Also, we have a ketoconazole range that is Kion, the most advanced range of ketoconazole. In Kion, we have a Kion Stay On lotion, Kion soap, Kion zip, Kion cream. So Kion is finishes the task completely. Gloderma is introduced the MinoBoost with a new improved pack that is minoxidil topical solution and tablet. MinoBoost the complete hair regrowth therapy. In MinoBoost we have a MinoBoost 5, MinoBoost F5, MinoBoost F10, and MinoBoost Pro Gain, along with the spray and applicator. Also, we have a oral therapy that is MinoBoost 2.5 mg cold tablet. So MinoBoost extra boost for the faster hair growth. Also, we have a core therapy, the Keraboost tablet. So in Keraboost, we have enriched with the D-biotin, N-acetyl, and L-cysteine. Along with that, we Keraboost have a IDDS technology for the site-specific drug release in a 3-phase. So Keraboost available in trichology pack of 30 tablets and 3 for 10 tablets. So Keraboost tablet boosts the hair growth, boosts confidence. Also, we have a launch a topacenib molecule in the management of autoimmune skin disorder. So in that we have a facetinib ointment which containing topacenib 2%. Also, we have a facetinib XR which containing topacenib 11 mg and facetinib which containing 5 mg tablet. So to facetinib rekindle the flame of hope. Also, Gloderma have a tie-up with Sanosun Baby, which is made in Germany brand. Prevent pediatrician skincare. So Sanosun Baby has a international collaboration with the Man and Shoulder, brings world-class derma tested certified with a natural and safe baby skincare product to Indian mothers. So Sanosun Baby, German's premium baby skincare, one globe, one formulation. 40 plus years of expertise in baby skincare and presence in 70 plus countries. So Sanosun Baby gained the trust of confidence of 250,000 plus Indian mothers. So Sanosun Baby made with the more than 90% natural ingredient, SLS paraben free, and it is clinically tested hypoallergic. So Sanosun Baby with the milk protein and organic olive oil. So that's all about the Gloderma. Thank you so much. Thank you all of you. Now I would like to hand over mic to the Dr. Sasi sir.
Thanks a lot, Rohit, for your introduction, and thank you for hosting us. So today, unfortunately, we don't have anybody else joining us for the mentorship program. I guess everybody is busy because we also had to postpone the date. But Dr. Nandakumar sir and myself are here, so we'll go through the cases one by one and see how it goes. Dr. Manoj Singh sir is due to join, but Not sure when he will join. So we'll go to case one straight away. Nandakumar sir, I mean, you want to take this? You want to, we can go through this alternately.
Yeah,
So this
correct.
is a 45-year-old female who presents with complaints of raised lesions on the face and neck for 3 months. On examination, multiple well-defined asymptomatic skin color to hyperpigmented firm papules and nodules of the face, neck, and upper back, with a few lesions showing eczematization, mild scaling, some associated with yellowish hue, and some demonstrating self-healing. So this is the clinical picture. You can see that the image here is a bit distorted, but you can make out the numerous papules and nodules. So pretty striking. You can see here, even on the neck. So 3-month history. So self-healing, some demonstrating self-healing, some with a yellowish hue. So I deliberately did not include a differential here on the clinical, but this is the histology. Nandakumar sir, you can describe it and give your differentials and low power and high power.
Can you select the better section? Which one?
Yeah, this one is a better section. Both are, I mean, both have, unfortunately, they seem to have been excoriated in the middle. So both sections show a defect here. That is an artifact, of course.
Yeah.
And this just has a small line there, but both sections are reasonably good, sir. Otherwise, apart from this defect here, right in the middle.
Yeah, it shows, sections from skin show actually epidermis with an area of erosion. It shows hyperkeratosis. Can we just go closer? There is mild irregular epidermal hyperplasia is there. And the dermis seems to be very busy. We are seeing plenty of infiltrate in the dermis.
So when I saw this case, I mean, the first thing I noticed was that it's a sufficient deep infiltrate, which seems
Both
to be
both
nodular.
are involved. Yes, we are seeing plenty of multinuclear giant cells.
Yes, lots of giant cells, even on low power, you can see them. And what is striking also is this particular bit here, which looks a bit necrotic, no, sir?
Yes, it is a focus of necrosis. Focus of
Yes.
necrosis is also seen.
Yes, yes. So we have a focus of necrosis, giant cells, granuloma formation.
Can we just zoom in on the granuloma? This one. We just take it a little closer. Yes, very good. Right. So we are seeing a well-formed granuloma with the multinuclear giant cells, histiocytes, sprinkling of lymphocytes at the periphery. And adjacent to that, we just now saw a focus of necrosis also, with few neutrophils, karyorectic debris and all. So essentially, the histology shows probably the patient has got the lesion excoriated also. It shows a dermal infiltrate with focal granuloma formation. The infiltrate is composed predominantly of mononuclear cells. Can we
Yes,
just
there are some other cells as well, sir. Here in the top, you can see here.
right?
Lots of neutrophils are also here.
Neutrophils. Many karyorectic debris are also seen.
Yes, yes, yes. And I thought this was probably the center of a follicle or something, because given the facial lesion,
Yes,
this could
probably.
be follicular-centric. Though it's difficult to say on without seeing the actual follicle.
Yes.
This may be an end-stage lesion because there's a focus of necrosis completely. Something has become necrosed, and here there's a defect, probably excoriated, and lots of neutrophils, and so there is a tuberculoid granuloma, lots of lymphocytes, histiocytes. It's not sarcoidal, is what I thought. Here the type of giant cell though is, this is a foreign body type giant cell.
Foreign body type giant cell. We have to discuss the differential diagnosis of granulomatous lesions occurring on the face. That too, we saw the clinical picture.
Yes,
The eroded papules, a few nodules were there.
yes.
The differential diagnosis of granulomatous lesions on the face. Of course, any of the major granulomatous lesions like Hansen's disease or tuberculosis can also occur on the face, but there are few which are more unique to the face, like a granulomatous rosacea, lupus miliaris disseminatus faciae.
Yes.
All these come into the differential diagnosis with the clinical picture.
Yes, sir. I mean, would you how much importance would you give to the necrosis, sir? I mean, would you call it? I mean, do you tend to give importance to the necrosis, or is this incidental thing, or would your differentials change based on the finding of necrosis here?
Yes, a tuberculoid granuloma with necrosis, I would tend to think more in terms of lupus miliaris disseminatus faciae.
Yes, sir. And acne, and do you tend to do you think acne agbinata is a different entity, sir, or do you tend to lump them together?
The literature actually, people have used it as an interchangeable term. But I think in acne agbinata, we find more of a diffuse sort of infiltrate also. Whereas in clear-cut lupus miliaris disseminatus faciae, the granulomas and necrosis are the standout features.
I tend to use them a bit interchangeably, sir. I think from my understanding, they seem to be overlapping entities where clear-cut differentiation either clinically or histologically is not really possible.
Yeah.
So though granulomatous rosacea is slightly different spectrum, does not normally presents as plaques and doesn't usually show necrosis. LMDF and acne agbinata, in my experience, tend to show more necrosis, and you can see the huge amount of necrosis here.
Necrosis, yes.
And the reason I'm saying this is probably a hair follicle is two things. One, though you're not seeing a follicle, most of the giants is a foreign body type, and this generally happens when there is a keratin extravasation, and that tends to produce foreign body granulomas.
Yes.
And especially the face, and given that there's a central defect, which is probably a hair follicle that has been picked out. Maybe there is a bit of transepidermal elimination of the granuloma here. We don't know. It's because there's a defect in processing. We can't really say. So that is why I thought this was folliculocentric. So would you think of any infective etiology, sir, in this circumstance?
Obviously, it doesn't look like a fungal granuloma. It doesn't. But I would like to do a special stain for acid-fast bacilli.
Okay. You would generally tend to do, sir, in this circumstance. In the clinical, given the clinical thing, you would still do acid-fast because clinically it seems to be pretty, consistent with LMDF or acne agbinata, I think.
I think for the part of workup, we will do.
Part of workup, you would do it. Okay.
Yeah, please.
So, in this case, I called it, LMDF, acne agbinata. I normally don't tend to, call it one or the other. I call it a spectrum and describe the entity and give a descriptive comments based on what the findings are and say it's within the spectrum. That is what I called it. I couldn't see any organisms here, and I did do FIGHT and I did do PAS as well, just for completion's sake, and they were negative because deep fungal infections can rarely cause, especially because you're seeing a suppurative granuloma here. But here the separation is predominantly in the epidermis near the infundibulum probably, and that is allowed because there's excoriation there. So that's only place you're seeing suppuration. So I thought that was allowed. It's not a pure suppurative granuloma in the true sense, is what I felt.
I mean, by way of discussion, how do we manage these patients?
So generally, in my experience, these patients respond pretty well to doxycycline with topical azelaic acid. You can give metronidazole and you can try even ivermectin sometimes. But generally, they tend to respond pretty well to doxycycline. If not, isotretinoin seems to work in Western cases, in my experience. And obviously, we have to make sure they're not using topical steroids because the topical steroid dependent phase is one of the commonest reasons for having this type of presentation.
No, you are right. Many times we get the biopsy after the patient has used topical steroids.
Yes, yes. Especially the patient was complaining of itching and all. The patient usually start with some sort of itchy skin rash, and then somebody prescribes steroid and they start using it all over the face, causing this type of presentation. So we'll see what everybody's answered. So 11 of so we've got 48 participants this time because there was a bit more time. I think we've got more participants. So LMDA for acne acuminata is the predominant diagnosis. So I'm giving them one. Lupus vulgaris, unfortunately, I'm not sure we can give them. I think they were a bit misled because caseation necrosis is a feature of lupus vulgaris, and but then the clinical is not that of lupus vulgaris.
Yes. That is the point. That is what I said at the beginning. We should be discussing more about the granulomatous lesions occurring in this clinical background.
So if you're looking at the histology alone, lupus vulgaris probably is the differential.
But the CPC is not in favor.
CPC is not in favor. So I don't think we should be giving any marks to lupus vulgaris. But
no, we cannot.
Same with sarcoidosis. This is not a sarcoid granuloma, unfortunately. Granulomatous rosacea can be, but clinically, I mean, it's a clear-cut case of LMDA for acne acuminata. It's one of the two you have to choose.
The patient has got lesions on the neck also.
Yeah, you can't really call this granulomatous rosacea, but unless somebody is such a lumper, they want to lump this into LMDF, then they should still be choosing LMDF.
and we are not seeing any follicle as such.
Yes.
Granulomatous rosacea, generally it is centered around follicles. We are not seeing that also. So I don't think we can give marks for granulomatous rosacea.
Do you want to give 0.25 because it's in the spectrum?
0.25 perhaps, yes.
Yeah. Because it's in the spectrum, we can give some marks. Cutaneous tuberculosis, unfortunately, no xanthogranuloma, multicentric histiocytosis, granuloma faciale, mycobacterial infections.
Long list of differential diagnoses.
Long list of differential diagnosis, but none of them are correct. Should we discuss them so that people understand?
There is no point. Why? One person has written is nodular tuberculin.
No idea why they thought. I mean, they thought it was heat reaction. I guess I don't know. Maybe it was a caseation necrosis. I mean, if it's on the body and somebody presents with multiple papules and nodules with caseation necrosis, a tuberculin reaction is certainly well worth considering. I have to agree. But not this presentation on the face and neck.
Yes.
This is not a tuberculin reaction. But if you're thinking of if it's not a tuberculin on the body, then it's okay. But the CPC is it beats it is completely against.
I think only these three will get a credit for that. Yes. First two, obviously.
Yes.
Granulomatous rosacea for.
Yes. Somebody called it neutrophilic dermatosis sweet syndrome. Actually, I missed that. I think they were misled slightly by.
Even lichen planus is offered as a diagnosis.
Yeah, but clinically it could be sweets. Clinically is a very good case for sweets, but then histology is not that of sweet syndrome. No. Not enough neutrophils, and also it doesn't present with granulomas.
Very good case actually.
So this is I didn't put a clinical picture, but 37-year-old female complaining of oral ulcers for 16 years, aggravated since 1 month, and I mean. You could dismiss this as an inadequate biopsy because you're not seeing any epidermis at all. But you can make out this from the lip because you're seeing muscle fibers, a bit of fat, and then you're seeing the lamina propria, the dermis of the mucosal surface, so-called. But then I thought this was classical enough. I could make a diagnosis even without. I didn't do a DIF on this, though you should. I think
on the left-hand side, I think that is the we can make a diagnosis. Yes.
So the clue here for people who are listening is that the epidermis is absent. So you're looking for the epidermis is absent because obviously it's an ulcerated lesion. The epidermis has been completely sloughed off. What you're seeing is this dermal papillae, and on the dermal papillae are sitting these acantholytic. So these are acantholytic keratinocytes, and this is what we call tombstoning. They're like tombstones. And this is the classical appearance. You don't generally see in any other condition. So even though you're not seeing epidermis and clearly you're not, see here are a few acantholytic cells here in the right in the center. I don't think you're seeing the pointer, but you can see that right in the center. These are acantholytic cells, keratinocytes, which are sitting freely in the just above the epidermis. So these are acantholytic keratinocytes, and all these tombstones are also sort of acantholytic keratinocytes, which are free from the surrounding their surrounding neighbors. So such a classical picture, you don't need. I mean, this is the case. I wouldn't need DIF. In fact, I didn't even do DIF. Clinically, I thought it was pemphigus vulgaris. Histologically, the features were very supportive. So lots of lymphocytes here. All these are lymphocytes for people who are learning Dermpath. Nice round nuclei, no multinucleation, single nucleus. And these are all keratinocytes here. And where the keratinocytes are in a single layer, you can see the tombstoning as well. Any other features, sir, you want to point out?
No, the one point which I would like to highlight is that in majority of biopsies taken from this mucosal surface, the epidermis may be absent, as in this case. You will find it slightly more difficult in interpreting the findings compared to a blister, which is an intact blister taken from the skin surface. So that point has to be kept in mind. We have to be diligent in picking up the findings in a mucosal biopsy, and also regenerative changes, especially in a subepidermal blistering lesion occurring on the mucosal surface. Regenerative changes can cause confusion in the interpretation. This is a clear-cut case of pemphigus vulgaris, and no immunofluorescence is required for this case. But even the for people who are beginners in this field, the infiltrate might cause some confusion in the interpretation. You shouldn't get carried away by the dense infiltrate seen in the subepithelial region. You should identify the area of genuine pathology, that is the suprabasal area. It is beautifully seen. We can see the tombstone appearance of the basal cells.
Yes. So actually, since we don't have any people who have joined the mentorship program this week, I think, Rohit, if you have any Gloderma team, if you have any questions in the question box, please just post them and we'll try to answer them, because the audience may be asking questions.
Yes.
Okay. I think we should also, encourage, all are requested to post queries or questions in the chat box. We will address them.
Yes, we can go back to the questions already discussed also. I think what you mentioned, sir, is very important. The dense infiltrate, normally we don't see it in the skin, but in the mucosal surface, because the erosion, there is a reactive infiltrate to some extent, right?
Yes.
But in the skin, you don't see such a dense infiltrate in pemphigus vulgaris anyway.
Yes.
So let's see what everybody has answered. Hopefully, most of them should have given full. They should have given the right answer. Pemphigus vulgaris, yes, there are two diagnosed for some reason, but 21 out of 48 have given the right answer. Over lichen planus, somebody has called. I think the dense infiltrate.
This is what I was saying.
You got it right. You read the minds of the students, right?
I hope I'm correct in missing the wood among the forest or something like that. Saying is there, isn't it?
Yes. So I think none of the answers deserve discussion, because it's pretty obvious. Plasma cell gingiva-stomatitis, there are no plasma cells. Sometimes it can cause a dense infiltrate, but there are no plasma cells, and this is not that. I don't think we should answer anything. Erosive lichen planus, see, the tombstoning is the thing. Lichen planus or erosive lichen planus, whatever you want to call it, when there's tombstoning, acantholysis, that's the answer.
Even one person has answered it as an aphthous ulcer.
Yes. 30 years history, 20 years history, unlikely. So let's go to there's something in the chat box. Question, vascular prominence in oral pemphigus. Is it because the mucosa is more vascular? Yes, I think that's basically it. The vasculature was a bit more prominent. Somebody has asked, why is the vessels prominent? It's an ulcerated region, so the vessels are bound to be prominent. I don't think there's any significance. Do you agree, sir?
Yeah. And there is no evidence of any vasculitis.
Yes.
Don't be mistaken by that vascular proliferation. It is only a reparative process or a reactive process.
Yes. So the next case is this: 76-year-old male complains of scalp lesions with surrounding pain for 6 months without pus discharge, but with occasional bleeding. 2 into 2 centimeter ulcer with granulate tissue and yellow pullulant discharge and vertex treated with unknown topical agents and multiple small hyperpigmented plaques over the bald scalp area. Differential diagnosis includes seborrheic keratosis, acne keratosis with secondary infection, squamous cell carcinoma, including out malignant melanoma. So this photo is a bit stretched, unfortunately, but you can make out the scab-like lesions here all over the scalp. And this is the histology. I think this is an interesting case. I thought, what do you think?
Yes, it's a case worth discussing. And it does cause confusion while signing out the report.
Yes, sir. Yes, sir. What did you think of this?
Think a markedly hyperkeratotic hyperplastic epidermis with a lesion occurring just beneath the epidermis. The islands of tumor cells, which at one area at least shows a tiny bit of peripheral palisading, dark staining nucleus.
Yeah, I'm zooming in that. Yes, sir.
Even we can make, whether it is artifactual, I don't know, a cleft-like artifact is also seen here.
Yes, sir. Somewhat cleft-like artifact is there.
Yes. But there is another tumor nest here.
Yes. Yes.
Where the cells are distinctly different from the first one.
Yes.
Here the cells are much more larger with more eosinophilic cytoplasm and vesicular nucleus. Some showing nucleoli.
Yes, sir.
But towards the lower portion, we are seeing some baseloid cells also, few. But so we are here also. We could see a combination of these two features in some of the cells. So one thing is we are dealing with a neoplastic process and not an inflammatory skin disease. It is a neoplastic.
This is on the edge of the ulcer, so that is why perhaps this skin looks relatively normal.
Yes.
Did you think this was showing any signs of malignancy, sir? This particular bit?
No, I thought there were a few dyskeratotic cells, but I didn't think about any.
Yeah, I mean, looking at this per se, there's a bit of spongiosis.
Yes.
The basal keratinocytes look a bit hyperchromatic, but I don't think looking at this per se, you can call this malignant at all.
No, not even in situ changes are not seen.
Here it's starting to develop. So as we go to the edge of the region, edge of the ulcer, that is where this is starting to develop. So
good thing is that the biopsy included this portion. Otherwise, the diagnosis could have been missed.
Yes, absolutely. So looking at this, when I looked at this case, I was a bit of puzzle. I thought, is this BCC as we described? This looked typically. If I was looking just at this, you would have called it the BCC.
Yes. Yes.
But then that alone is not enough. We are seeing other clearly squamoid cells. There's clear squamous atypia, and here the changes in the junction here look definitely SCC-like. It's more of a keratocytic, not just basal cells. The entire full thickness of the epidermis is involved here, and beautiful mitotic figure right in the center here. You can see for people who are. This is an atypical mitotic figure. This is not normal mitotic figure. It's an atypical mitotic figure as well. So there is. So what do you? So while we're at this, and because most of the audience are probably novices, what made you think this is malignant? Probably that is what they would want to know.
One is, I mean, the island of cells beneath the epidermis with distinctive features suggestive of a basal cell carcinoma. And the island adjacent to that shows definite features of squamous cell carcinoma. We are seeing pleomorphic nucleus, atypical mitotic figures, etc. So there is no question that it is, and even on the lower portion, there is evident pleomorphism. You can see another atypical mitotic figure just at the periphery.
Yes.
So there is no question of it being malignant. It is a malignant tumor. What to call it? That is the question.
Yes, absolutely. So this is a mitotic figure, and
Yeah.
the cells are all pleomorphic, different sizes. The nuclei are also not the same. So these are the pleomorphism and all that features of malignancy. And these islands should not be here. That is a basic thing. Even on LOPA, you can make out these islands are not supposed to be here. And the fact that they're there makes it malignant even without looking at the cytological features, we can easily say. But the cytological features are those of malignancy as well. So, sir, would you call this a BCC? Would you call it SCC or a basosquam without IHC, of course?
Without IHC, I would call it as basosquamous carcinoma.
Basosquamous carcinoma. So, basosquamous carcinoma, do you tend to treat it more in the more like an SCC or BCC, or what? How intensive is your treatment?
More in it would be managed more in the line of squamous cell carcinoma.
Yes, yes. I think that is very important because if somebody is just calling it a BCC, you're actually lowering your guard down. You're actually
Yes.
you're under-treating the patient. But if you're calling it an SCC, I think you are going to treat the patient correctly because this is not a BCC. If you call it a BCC and sign it out, I think people are missing the boat.
The learning point is that you shouldn't sign this off as BCC, having seen the other islands of cells, because the prognostic implications are different. A basal squamous carcinoma is a much more aggressive neoplasm.
Yes.
So
Yes.
that is the important take-home message.
Yes. And we can call it a squamous SCC with some
basaloid differentiation. That also
that can be done. Now, do you think it's important to do IHC, sir, here, or would you be happy not to do IHC and treat this case?
Because I'm seeing this left-hand island, I wouldn't require IHC in this case. But otherwise, IHC may be required.
I agree, sir. I didn't do IHC in this one because I said this is SCC and I didn't, I didn't do IHC in this one.
Yes. I think for those audience who are in the dermatologists among the audience, this is the features of malignancy, features the subtle features of basal cell carcinoma, how to interpret the other island with the evident squamous differentiation, and how we arrive at a complete diagnosis. So this is basal squamous carcinoma. For the pathologist, it might be slightly more easy, but for a dermatologist, recognizing the neoplasm would be slightly difficult. That is why I'm telling this. Good.
Yes. So let's see what everybody. Oh, there's a resound there. Why is there a resound suddenly? Rohit, is there a reason for the resound? No, it's not. Stopped. Okay, fine. So 14 people have called it acne keratosis. Unfortunately, I don't think we can call it an acne keratosis. Would you give any marks to that, sir?
No, because if the invasive component is very evident, we cannot call it.
I don't think you can call that. Oops, sorry. Squamous cell carcinoma, well differentiated. I mean, you can call it squamous cell carcinoma, moderately differentiated, but well differentiated.
we are not seeing any keratin pearl or anything like that. It is not well differentiated. Moderated differentiated, we can give 0.5, but not for well.
Are we giving any marks for calling it squamous cell carcinoma? 0.25 at least?
0.25, yes.
Yeah, if we're being a bit generous. Bovinoid acne keratosis. Again, I don't think we should give that any marks because if you call it acne keratosis, you're under-treating the patient.
Yeah. 5 has answered it as moderated differentiated squamous cells. That will get 0.5.
Sir, but see, in this particular marking system, they have we don't have a basaloid SCC in the differentials, I think. So I was expecting them to diagnose.
Number 16 has answered it as basal cell carcinoma.
Basal carcinoma. So I thought if somebody has put both answers, basal cell carcinoma and squamous cell carcinoma, then they should get probably 0.75 for SCC and 0.25 for BCC. That is what I thought.
Yeah, I agree. Agreed.
Are you happy with that? Okay. So irritated sepke, acantholytics, acne keratosis, unfortunately, none of them will be getting any
See,
marks.
this was what I was talking about. 9 has answered it as verruca vulgaris. That person has completely missed the neoplastic part of the section. That is what
Yes,
I was talking about. You
yes,
shouldn't
yes.
miss it.
BCC 0.25, that's about it. We can't give anything more than that. Acantholytic sepke, malignant melanoma, Ka like squamous cell carcinoma. I don't know why they even thought Ka, because I think the glassy cytoplasm they were a bit deviated, because some of the but glassy cytoplasm is just one of the features of Ka that doesn't make it a Ka like SCC, and the clinical is not that of Ka like SCC anyway.
And that person has missed the basal cell carcinoma part also.
Yes. Okay, so we'll submit that answer right now. Okay, right. So let's go to case number 4. Case number 4, I don't know history available. I don't know why I said that. This is a case that actually Dr. Manoj Singh sir sent. Unfortunately, he's not here. And he sent it as something else, but I thought this was something else. So, sir, you can maybe describe this and I'll tell you what he's thought it was, but I don't think it is that. Maybe there's a misdiagnosis in, maybe mislabeling of the slide. Maybe.
Can we just zoom it a bit?
Okay. Do you want to describe the silhouette size? Tell me what you think then for the audience. On the
I mean, right hand side, we can see the epidermis.
So on the
Right hand side.
silhouette, it appears like the epidermis seems to be slightly invaginated here, and it seems
Yes.
to be sort of a crateriform lesion, a tumor arising from the epidermis, right? Crateriform nodule, and
And probably ulcerated.
and ulcerated on the surface, yes. And lots of keratin pearls. It's definitely a keratotic lesion, and you can see this thickened collagen bundles in between the keratin, islands, which seem to be infiltrating in between the collagen bundles, which appear quite thickened as well.
Yeah, I mean, histology-wise, it is a clear-cut diagnosis. I would call it as can I say? I would call it as well-differentiated squamous cell carcinoma.
Well-differentiated squamous cell carcinoma. What about keratoacanthoma, sir? Would you consider that?
But we are seeing this definite
Infiltration.
invasive component is there.
Yes, yes. There's a definite invasive component. And this sort of, if you are seeing, care is usually much more well circumscribed. You don't see this much of invasive component, and a reactive stromal reaction can be seen sometimes. I mean, could it be a regressing K maybe, if somebody is calling that? Would a regressing K have these features, or would you not think that is possible?
Keratoacanthoma can have this stromal reaction, especially just beneath the lesion. We can get inflammatory cell infiltration and things like that. But having identified definite features, I mean, definite invasive component, I think we have to call it as well-differentiated squamous cell carcinoma, and not K. Again, the terminology keratoacanthoma might give a false sense of complacency on the part of the treating clinician.
Yes, yes. One thing I think for the people who have seen the previous case is that the cytoplasm here, the why this is well differentiated is that there's not much ATP, the nuclear ATP and the cytoplasm, the cellular ATP is not as prominent as in the previous case, where we said moderate differentiated. No, sir. Here there is a glassy cytoplasm, and there is some loss of polarity here. The cells, the basal cells are not looking basaloid; they're looking more cuboidal or rounded. So that is the feature. But then, like in the other case, this is more well differentiated. The cells are just glassy, but there's not that much of loss of polarity and pleomorphism in the previous case. That was what we called moderately differentiated.
The only thing is we can see the strands or islands of tumor cells jabbing into the dermis, infiltrating the
Yes.
dermis, and
Yes.
plenty of horns also.
Yes, horns, lots of horns as well. So yeah, for people who are wondering why this is well differentiated and why that was moderately differentiated, I hope the distinction is clear. That's why I put both the cases side by side, because it's a good learning experience. So somebody has asked, how does baseline SCC differentiated from basosquamous carcinoma? Do you want to answer that, sir? How
Yeah.
does baseline SCC differ from basosquamous carcinoma?
Basaloid squamous cell carcinoma will show areas of basaloid differentiation in an otherwise squamous cell carcinoma, in an otherwise histologically squamous cell carcinoma. Basis squamous carcinoma, we have components of both basal cell carcinoma and squamous cell carcinoma. So a basis squamous carcinoma, invariably the diagnosis would require, unless the features are so clear cut as in our case, will require IHC. That is the basic difference.
Yes. And in the IHC, if the basaloid islands do not stain with BEV-P4, etc., then you call it basaloid SCC.
Yeah.
If it does, then you call it basosquamous, because then meaning it's a combination of both BCC and SCC. Yes, sir. So let's see what everybody has said. This is a straightforward case, so we don't need to spend too much time. We've discussed already. So case number 4, squamous cell carcinoma, well differentiated. I think that's good. So somebody has called it KL like SCC, but then I think this is SCC. KL like SCC is also in the spectrum, so I don't think we should not penalize them. I think that's a reasonable differential. Though without the clinical history, it's difficult, but KL like SCC is okay. I thought that was okay. Basis squamous, somebody has called it for this. This is not basis squamous.
Here there is no basaloid component.
They were confused. And moderated differentiated, I don't know. 0.5?
0.5.
Irritated SEP case, somebody called it a BCC infiltrator. I guess because they were confused by there's so much infiltration. BCC is definitely infiltrative, and the infiltrative pattern, they called it BCC. But that the pattern alone does not make it a BCC. It has to have basaloid features. Pilometricoma, calcified. So this is what I was, so the slide was sent to me labeled as pilometricoma, malignant pilometricoma by Dr. Manoj Singh, but I think that's a mislabeling. I don't think he was even confused about pilometric. I think that was just mislabeling, but I don't think by any means this is a pilometricoma. There are no, I think the ghost cells, I guess, they thought the glassy keratinocytes were ghost cells. Maybe that is a confusing factor, maybe, perhaps. Do you think so? Maybe somebody was confused by the glassy cytoplasm. They thought these were ghost cells here.
But it would be a crime to miss the diagnosis of squamous cell carcinoma in this slide. We shouldn't.
True. Signet ring cell squamous cell carcinoma. These are not signet ring cells. I guess we need to show, or somebody whoever has answered this has to see a picture of signet ring cell to actually understand why it's not that. Adenoid, this is not adenoid squamous cell. I mean, are we giving any marks to these squamous cell carcinoma variants? It's a squamous cell carcinoma diagnosed.
No, I will see. Somebody has made adenoid squamous cell carcinoma. This is not adenoid. Eruptive keratoacanthoma, no, I don't think so. It is acanthotic seborrheic keratosis. No, we cannot give marks for that.
Desmoplastic squamous cell carcinoma. What do you think about that?
0.25.
There's a desmoplastic reaction, fair enough.
Yeah, there is, but the features are more in favor of a well-differentiated squamous cell carcinoma.
Perhaps 0.5, sir.
0.5. All right. Okay. Morphia 28 has answered as morphia.
Okay, we've got 3 more cases.
There is a query in the chat box. Somebody has asked what is a pseudo-horn cyst. Can I just see the
horn cyst, pseudo-horn cyst, and keratin pearls?
Keratin pearls. See, the basic thing is the horn cyst or keratin pearls associated with squamous cell carcinoma will show malignant cells within the nest, within the cyst. So that is different, right? We can see horn cysts in seborrheic keratosis also, but they do not show any pleomorphic cells within the cyst. So once you identify pleomorphic cells like this is what is called as keratin pearls of squamous cell carcinoma. It is only the terminology is interchangeable. I cannot say that which is benign and which is malignant, but the key thing is to identify a keratin pearl or a horn cyst associated with well-differentiated squamous cell carcinoma. That is by identifying malignant cells within that cyst.
So, for example, if you're seeing this, you won't be able to say, no, sir, this could be...
Correct. Correct. That can be seen even in this can be seen even in a seborrheic keratosis.
Yes, yes. And what about pseudo-horn cysts, sir? Would you try to differentiate between pseudo-horn cysts and horn cysts?
I actually don't know how to differentiate. I'm sorry.
Yeah, I don't think that is a... I mean, there's a lot of terminologies that people use.
Yes, yeah.
Yeah, they're
benign versus malignant, we have to be very clear in our mind.
There's a video on YouTube by Gerard Gardner. He has explained excellently with the video photographs and everything of how to differentiate keratin pearls and pseudo-horn cysts and horn cysts. Yeah. So if the audience, whoever is interested, Google on YouTube Gerard Gardner and keratin pearls, you'll see a video. It's a very nice illustration, actually. Okay.
Right.
So next case number 5. So asymptomatic small growth in the lip present for 6 months, which is increasing in size over the past 2 months. Hyperpigmented flat papule was observed on examination. So this is a lip lesion. You can see here. This case, actually, people who attended the DSI annual meeting in Delhi would have seen this case. I submitted this as a challenge case. Sir, were you there for the discussion?
Yeah, I was there.
Yeah. So for people who are looking at slide for the first time, this is actually the biopsy from the lip. And you can make out it's a lip even without seeing it, or you can make out it's because of the surface, because of the muscle tissue, nice, muscle tissue here, all this pink round.
Again, a beautiful image for beginners to identify it as a lip or a biopsy from a tongue or a lip. We find this smooth muscle bundles. So nicely seen.
Yes. So that's how muzzle looks like. So in case ever you're confused as to what pink structures are in the skin, if you see this image multiple times, you'll know what muzzle looks like. So what we are seeing here, apart from the muzzle, which is normal, we are seeing these huge spaces in the mid-dermis. Some spaces are also in the superficial dermis. These spaces look a bit irregular. And they are quite large, a bit cavernous to an extent. And they're lined by, when you look at these spaces, they're lined by a single layer of endothelial cells. Whenever you're seeing a vascular lesion with spaces, we want to rule out malignancy. And the way we rule out malignancy in vascular lesions is to look at duplication of the lining. So here it's a single layer of lining. They're not multi-layered. And the cells look relatively banal. They don't look malignant. There's no mitosis or there's no pleomorphism. They look pretty banal, actually, the endothelial cells lining it. And here, however, is an unusual thing going on. Within this large vascular space, and the vascular space goes on from here. It is going on from here all along the structure. You can see these pink structures which look like muscle bundles again. But these are not muscle bundles. These are basically papillary projections within the within the lumina of the vessel, within the lumina of the vessel, and this has got a particular term to it. It's called Mason's tumor or papillary endothelial hyperplasia, where you have these papillary projections again lined by a single layer of endothelial cells. And they have a hyaline core, which looks very eosinophilic. And you can see these sort of cells within the core, which are again inflammatory cells, a few maybe fibroblasts, maybe there. In contrast to these muscle bundles, which don't have anything inside. The nuclei of the muscle are outside the eosinophilic blob. So these are not muscle bundles. And very easily confused if you're looking at that and this. And so basically, this is a reactive condition, papillary endothelial hyperplasia or Mason's tumor. Whenever there's thrombosis, this is a thrombus. And what this is a vascular, dilated vascular channel, is a venous lake, typical on the lip, on the lower lip. And why this is venous and not arterial is not seeing any muscular layer around it. And it's too big for a capillary. These are capillaries here, which are slightly dilated and probably reactive. But this is a large venous lake within which there is some thrombosis. And in reaction to the thrombosis, often what happens, there is endothelial hyperplasia, which takes the form of small papillae. And this is called a Mason's tumor. Benign, completely benign, excision is curative. Nandakumar sir, do you have anything to add?
The key to the diagnosis, first in identifying the vascular space. That is done by the identifying the endothelial lining. And perhaps we will be seeing some RBCs also within the lumen. So that is how we identify something as a vascular space. The space lined by endothelial cells. Why this is not malignant? There is no multilayering of endothelial cells, no pleomorphism of endothelial cells, nothing like that. It is just a very flat single layer of endothelial cell lined vascular space. And the papillary structures, as Dr. Sasi rightly said, it can be mistaken for the muscle bundles which we saw located lower down. But these papillary structures are also lined by the similar cells as the vascular, the endothelial cells, the flat endothelial cells. So this is again a beautiful image of intravascular papillary endothelial hyperplasia. We shouldn't mistake this for a vascular neoplasm like hemangioendothelium or something like that. That is the key thing. Why it is not hemangioendothelioma is that there is no proliferation of endothelial cells. The hemangio part is there, but there is no endothelioma. There is no tumor there. This is only papillary structures lined by benign, unprovoked endothelial cells.
Yes, sir. So I thought this was still an interesting case to discuss because not everybody would have attended the DSI meeting. So case number 5, so a lot of people have diagnosed venous lake, and so normally if you give them 1 mark for each, they would get full points. But then, I mean, both are good answers. Venous lake alone, I think, would get
0.75.
0.5. Intravascular would get 1 mark. I think that way it would be fair if people have put both the answers. What do you think,
Yes.
sir?
Yes, because the number 2 has identified the key feature, no? Intravascular papillary endothelial hyperplasia.
Papillary intralymphatic angioendothelioma.
This was what I was talking about. There is no oma there. There is no oma there.
Yes. Yes. Mucocele, unfortunately, not clinically. They thought mucocele, which is good, but that is not the histological diagnosis. Lobulary capillary hemangioma, again, this is not, though it is lobular, it's not a capillary hemangioma. I mean, the endothelial hyperplasia looks a bit lobular to an extent. I don't know where the others have come from, actually.
The first half, I mean, credit is there for identifying it as a vascular lesion. I appreciate that. But the rest of the second half have not identified it as a vascular lesion.
Somebody has called it angiosarcoma.
Yeah.
Intravenous PG, that is an interesting diagnosis. They saw that's what I'm saying. They saw the capillary, they saw the lobular proliferation inside the vein, and they call it intravenous PG, which is, I guess, if you don't know about Mason's tumor, you would call it that.
Maybe 0.25 for that person, perhaps.
Would you give it, sir? I don't know. It's nowhere near PG. The only thing they have done.
Prurigo nodularis angiolipoma.
I think those are clinical diagnoses. They didn't know the histology. They were given a clinical diagnosis. Angiolipoma. Okay. They didn't call it a myolipoma.
No.
Angiomyoma. Angiomyoma would have been interesting because there's a muscle bundle. They thought muscle bundle and angio. But angiolipoma, I don't know where they call it from.
I think there was a bit of a discussion even during the DSI regarding this slide. I remember.
Okay. Great. So that's that. Then we have next case. 14-year-old female with multiple itchy papules and plaques all the body on and off since 3 years. No family history of similar lesions. Few erosions, scaly plaques, solid papules over neck, upper and lower extremities. Little response with topical steroids. New lesions keep coming. Biopsy done over erosion of the right ankle. So there, this is the histological picture. There's a small erosion, and the biopsy was done from there. And you see multiple excoriated lesions and papules and nodules. Okay, so let's go to the histology. I think the histology is, we have to describe the histology as is. And this case, unfortunately, we don't have the scan slide, but I thought this would be interesting to see how people diagnose on a multiple digital images. So low power, it's showing marked epidermal hyperplasia. We have two sections within the same thing. And you're seeing a lot of serum crust and huge spongiotic vesicles here. And
Yes.
the image is not even in low power.
Yeah.
I'm not going to zoom in because this is a digital image. If you zoom in, it will lose clarity. I'll have to go to the higher thing. Not much going on in the deep dermis. Most of it is there's a papillodermal lymphocytic infiltrate and there's irregular epidermal acanthosis. So going up to the next level, here pretty much similar findings to what I've already described. A few dilated capillaries, lots of lymphocytes, serum crust. This is all serum crust. All this pink eosinophilic material is serum crust.
I think, this has to be highlighted. This is the appearance of a crust.
Yes.
And one shouldn't mistake this for portware microabscess.
Yes, yes, sir, yes.
So
I think I have a close-up of the crust as well here.
Yeah.
Here,
So this is a crust. So we can see the dried up exudate, which is a proteinaceous material, along with the intact as well as fragmented inflammatory cells. So this is crust.
And huge intra-epidermal spaces, spongiotic vesicles probably containing fluid, quite huge lesions. Normally we see this in pomphilics, but unusual to see it. I mean, this much of inflammation, florid spongiotic vesiculation. There's obviously spongiosis here. You can make out the desmosomes. And these are spongiotic vesicles. I was looking hard for scabies mite, but couldn't find anything there, in these sections at least. And you're seeing here a few dilated capillaries with a few lymphocytes. Anything else here in the other sections? Any other features, sir, you want to point out? Anything specific?
Are there any eosinophils among the infiltrate?
No, sir, I couldn't see any significant number of eosinophils anyway. There may be odd one that may have missed, but I couldn't see any significant.
We are not seeing any foreign body like what we expect in an insect bite or something like that. Nothing like that.
No, sir, no. What do you think, sir? What do you think? So 14-year-old female, 3-year history.
This lesion has present since 3 years.
All multiple lesions, not this particular lesion. But she's been having recurrent lesions over the body, neck, upper and lower extremities. And new lesions keep coming and some response, only little response to topical steroids. What would you call this? How would you sign this out?
Subacute spongiotic dermatitis. A possibility of a nummular eczema can be considered.
Yeah, but these are more papules and nodules is what.
Yeah, I agree. But the histology wise, this much of dried up exudate and epidermal hyperplasia with spongiosis. Histology sort of fits in with that of a nummular eczema. I agree that the clinical doesn't. But then I would just be signing it off as subacute spongiotic dermatitis. Needs CPC, that's all.
Yes. What as a clinician, how does it help you, the report? Do you think the report is helpful for the clinician? What would you suggest?
I would manage it as an eczema.
Manage eczema. Probably, I mean, I would probably still have papillary urticaria as one of the top differentials and ask them to rule out scabies. I think that's what I said in the report, because such amount of acute and spongiosis and all, you're bound to, I mean, you have to rule out scabies. I mean, though patient is having for 3 years and there's no family history or insect bite, some amount of mosquito bite or something, if patient's atopic, a history of papillary urticaria, no, history of atopy needs to be considered, and papillary urticaria would be in my top differential actually.
Nobody else in the family has similar lesions, isn't it?
Nobody else has lesions. So that rules out scabies, but then papillary urticaria is in the...
Still there.
Yeah.
It's a young patient, isn't it?
Young patient, 14-year-old, yes.
Yeah.
So here you go. The top answer is discoid nummular eczema dermatitis. I think we have to give that full marks. That is a reasonable diagnosis.
Yeah.
Prurigo nodularis.
No. This is not the histology of prurigo nodularis.
Yeah, I mean there is prurigo, but this is not histology. Dermatitis herpetiformis. Unfortunately, no, this is not. Subacute spongiotic, as you said, we should give that full marks as well.
Yes.
Prurigo simplex. Can that cause these sort of changes?
But the epidermal hyperplasia is too much for prurigo simplex. But 0.25 perhaps.
0.25, yes, perhaps, yes. Prurigo simplex, if I give a diagnosis, I wouldn't be happy with that. Yeah. Allergic contact dermatitis. I mean, difficult to call this allergic contact dermatitis. They've called the dermatitis aspect fair enough. But
we cannot label it as allergic contact dermatitis.
No, that is difficult. I mean, that's a negative mark. Acute spongiotic dermatitis. Acute, there is definitely acute component. It's not, they've missed, I mean, but it's subacute, but they've called it acute. 0.75 or 0.5? What do you think?
0.5.
0.5. Okay. Bullous lichen planus, unilateral diagnosis. I don't know how that came about. Bullous pemphigoid neutrophil-rich. There's not even much neutrophils actually. Spongiotic dermatitis with impetigo. That is certainly a possibility. I think we cannot rule out impetigo. Though there are no neutrophils there. There's a lot of sebum crust. What do you want to do, sir, with that?
Serum crust is there, but I mean, I personally, I didn't think of impetigo. It came as a surprise. That is why I'm unable to answer straight away. Maybe we can give 0.5.
0.5, yes. Okay. Reactive perforating tinea, subcorneal pustular dermatosis variant of IgA pemphigus.
No. That person has missed the spongiotic blister.
Yeah. And it's not there's no subcorneal pustules. I mean, that has
that is what I was trying to say. This is crust, and it should not be interpreted as a subcorneal pustule or I mean, this the parakeratotic abscess that we see in psoriasis and all. That should
and the same with the impetigo. Impetigo should have a subcorneal pustule, and that's why we do that.
Yeah.
So PLE, contact dermatitis, circumstantial dyshidrotic eczema, pamphylix. I mean, it's a wrong. It's a right histology, but the wrong site to call it dyshidrotic dermatitis eczema or pamphylix. I told you that's what I said. Histologically, it resembles pamphylix.
But I think that person should be given some credit for dyshidrotic eczema.
For diagnosing the histology.
Yeah.
How much do you want to give? So clinically, it is not that.
Maybe that person is a pathologist, not really exposed to the clinical part.
0.25 then.
0.25.
Okay. I don't think remaining ones deserve any mention. Pustular psoriasis, yeah. Okay. So let's submit that, and we've got one more case.
There is a question in the chat box.
Okay. Let us just see that. So what should be the ideal site of biopsy in this case?
Can we have the clinical picture?
I guess they were referring to the fact that the regional biopsy may be from this ulcerated lesion, and the biopsy was not obviously done from the ulcer, it was done from the surrounding area. Obviously, you want to biopsy a non-ulcerated lesion, but then if you're biopsying a surrounding area, that's okay, reasonable enough. You don't want to biopsy the ulcer because that will give you no information whatsoever.
Correct. Agree.
Yeah. I mean, this also would be a reasonable site to biopsy. If you're
Yeah.
biopsying a completely non-ulcerated lesion, also it's fine.
I think but the thing to remember is we should do a biopsy from an early lesion in such situations.
Yes,
So that the secondary changes will not be superimposed.
absolutely. So this is the last case, 26-year-old female, itchy, dark, raised lesions over hand and legs since 2 weeks. Pigmented pruritic excoriated papules scattered over hands and legs. And she with lichenoid pruritic small plaques over dorsum of both feet, pleva versus LP versus others. That was the differential given. And you can see these pictures here. Oops, sorry. You can understand why they thought slightly lichenoid maybe. Biopsy was done from the arm here. Some lesions on the wrist as well, which you can understand why they thought lichen planus. So, I mean, the reason I put this up is to contrast and compare with the previous case and the nice clinical description to contrast with the clinical description as well.
So straight away we can say that this is not lichen planus.
Yes, absolutely. And similar to the previous case, we are seeing nice cecum crust here.
Yeah.
A few neutrophils are there. Whenever there is cecum crust, you do see a few neutrophils.
Yeah, I would request the audience to see this is serum crust, and this should not be mistaken for a subcorneal pustule of SCPD or impetigo. This is not that. This is serum crust.
So in subcorneal pustules, you don't see cecum crust, no, sir. That is a clear difference.
We don't find this exudate part.
Yeah, this is a proteinaceous exudate which gives that pinkish hairline color, and that proteinaceous exudate is not present in pustules, subcorneal pustules, which are basically just water without any protein in it.
Correct.
And you see neutrophils, so but that doesn't make it a subcorneal pustule. Any excoriated lesion can have neutrophils. And you're seeing a nice spongiotic vesicle here, lots of spongiosis. So going back to the low part, you're seeing irregular epidermal acanthosis. It's not psoriasiform. Psoriasis is much more regular. So this is irregular epidermal acanthosis. There is
the key features of spongiotic vesicle is seen in this section. I think it is on the right-hand side section. It is more clearly seen. We can see the remnants of intercellular bridges.
Yes.
So it's very nicely seen. So this is the typical microscopy of a spongiotic blister with exocytosis of inflammatory cells.
Yes.
Shouldn't think about an acantholytic blister or anything like that with this. This is spongiotic blister.
Yes, sir. I think that is important differential. Acantholysis is not there.
Yeah.
Lot of spongiosis. There is parakeratosis here. You can see that even here you can make out parakeratosis, and there is hypogranulosis, not hyper. So if you think of lichen planus, that is one more clue. But I mean, you should not be thinking of lichen planus here by any means. There is no lichenoid infiltrate, though maybe in an excoriated or in a very spongiotic lesion, sometimes the basal layer is damaged, and you're not seeing any basal layer here. That doesn't make it lichen planus.
Yes.
And you may also see a bit of pigment incontinence. That is just a pigmented keratinocyte, of course. But again, even if you're seeing a bit of pigment incontinence, here you're seeing a bit of pigment incontinence. That's melanin here, melanin deposition here. Again, that does not make it a lichenoid reaction. And there is a moderately dense lymphocytic infiltrate in the upper dermis. So again, this again is a subacute spongiotic dermatitis. Sorry, would you agree?
Yes.
In the same spectrum, because there's acanthosis, epidermal hyperplasia, not as much as in the previous case, but it is still in the same spectrum. And given the 2-week history here, the history is that of 2 weeks. Itchy, dark, raised lesions of hand and leg, pigmented excoriated papules, hands and legs since 2 weeks. I mean, it's a very odd presentation. One would expect, pleva I thought looking at the clinical pleva it would show changes of pleva actually, but there's no signs of pleva on the histology. So it's a very, I mean, sometimes you don't really, histologically, you can't give an answer to the clinician, or if you're the clinician, you can't get an answer in histology. At least you can rule out pleva, you can rule out lichen planus.
Correct. That helps the clinician, that helps the clinician. This is not pleva, this is not lichen planus, this is not psoriasis.
Yes.
So that actually, reduces the number of differentials for him or her.
Yes.
So the management part, that is good.
So maybe some sort of papillary urticaria, viral exanthems would have caused.
Yes.
Yeah. So let's see what everybody has answered. So 17 have answered pleva. So clinical. Unfortunately.
The only thing is one thing to remember is that the histological diagnosis pleva is not always straightforward. It is slightly difficult, but this slide doesn't show any features to think about pleva. We shouldn't think about
pleva. Is a spongiotic and lichenoid in a reaction pattern. You should have both. Just a purely spongiotic pattern cannot make it pleva.
And a bit of vascular component and all these things.
Yes. Lichen planus, definitely not. Subacute spongioid dermatitis, again, we're giving one.
Yes.
Pleva, and this is repeated. Discoid nummular eczema dermatitis. I mean, what are you going to give this time, sir?
0.25.
Lymphomatoid papulosis, unfortunately, no such features. PLC, pityriasis rosea.
Acute spongiotic dermatitis also 0.5.
0.5 on this one, yes. Hypertrophic LP, lichenoid dermatitis. Papillary urticaria can be given, sir. I don't think so.
We can give some credit for that.
I think, even if you're giving full credit also, I think that's reasonable because...
Yeah, it is reasonable.
Yeah. Vigo nodulus, definitely not. Drug eruption, no, I don't think that's... No. I think that's that, sir. Shall we mark it? Okay.
Yes.
Excellent. So we finished much more quickly today, given that we don't have...
we took 75 minutes. Yeah. We missed the interaction with the junior members. If they were present, it would have been much more interesting. But the cases, all the cases were very good. I enjoyed discussing it. Excellent cases for discussion. I'm sure that whoever is attending this CPC would have benefited by the demonstration of the subtle findings of each case.
Yes. So let me just stop the screen share and check the results, because that's have not been populated yet. Yes, probably we'll wait for the results to be populated. The system will take some time to populate them. Otherwise, we'll announce them on the website later. So I don't think there are any other questions in the chat box. Rohit, are there any other questions?
No, sir.
Okay. And, thank you, sir. Thank you for joining the session, and thank you, Glodama team. And we'll meet again in a month's time.
Thank you, Sachin. Very for the excellent selection of cases. Cases which are really, I enjoy discussing these slides. Very good. Thank you very much. See you.
Thank you, sir. Okay.
Thank you, sir. Thank you.
Good night.
Good night.